Good evening, everyone. Welcome. My name's Phil Anderton. I'm the Managing Director of ADHD, and I'm delighted to be joined tonight by one of our very senior clinicians, Rebecca Whelan, who's got a history in the CV as long as your arm, and one of our patients and also an employee of ADHD 360, Archie Read. Rebecca, would you like to introduce yourself to the participants of the webinar?
I will. Good evening. So my name is Rebecca Whelan, as Phil's just kindly introduced me. So I work for ADHD 360 as the Deputy Clinical Director. And what that means really is that I am a clinician by background. So I have an extensive background in mental health, psychiatry, and as a specialist ADHD practitioner. So I currently, as part of my clinical work, I oversee clinical standards within the organisation. And I'm also a clinician, so I assess and treat patients for ADHD.
Excellent, and I think we'll probe your CV at relevant times in the process as well. So Archie, similarly, go on, introduce yourself, fella.
Yep. So I'm Archie Read. As Phil mentioned, that I'm a patient with 360, been a patient with 360 since 2019 now. Which is when I started my ADHD journey, if you will. And I now also work as part of the office team in our Sheffield office for 360. So helping Rebecca do what she does on a day-to-day basis.
Much appreciated as well.
Bless. Let's keep that kindness running. Archie is being very humble and disingenuous to himself. 21-year-old young man with ADHD and autism, who's managing a degree whilst working almost full-time for us in the Sheffield office, and has been promoted twice in the organisation because, quite simply, he's actually on it and he's brilliant. And he's with us tonight as a shining example of what a solid diagnosis can do for someone to change their life and make things happen. And I'm hoping that you'll see in Archie tonight what we see in him every single day. Let's throw the pebble in the pond and start things off. Rebecca, you've been working in mental health for many more years than your youthful looks would portray. Why ADHD? Why have you decided to specialise in ADHD?
It's a big question, that one, isn't it? It's a really big question, but the straightforward answer for me is I enjoy working with the patient population, with the ADHD community, whatever name we want to say. I enjoy a specialism. So yes, I have got an extensive history of working in mental health. That has set me in really good stead for working with some of the people that I work with on a day-to-day basis. So I can look at a person from a holistic perspective, considering their ADHD and other aspects of their maybe their presentation. So for me, ADHD is a specialism whereby I can achieve good results for my patients, and I think that's really important to me. Getting up and coming to do my job is around my patients, and to be able to offer the service that I offer in terms of my assessment, my input, my clinical intervention makes that completely worthwhile. So I think that's the short answer to it, Phil, really.
It's the honest answer as well, isn't it? It's a therapy area where we know we can make a difference, and a good solid diagnosis is the start of that process, and that's what we're here to discuss. Let's flick that lens into Archie for a second then. What did your diagnosis do for you? That's a tough question for a 21-year-old.
Yeah, well, I think probably the simplest way to put it, it changed my life. I was going from, at that point, I just finished my GCSEs, just sort of almost coasted through my GCSEs, didn't achieve anywhere near my potential at that stage, didn't have any plans on going to university at that stage, didn't even want to really think about A-levels. And it's at that point that started, but it was almost by chance, really. I sort of heard a conversation about someone with ADHD, and the words that they used, they said, "I'm an A-grade conversationalist, but I'm a C-grade student." And I thought, wow, that is me. And that's what sort of really sort of kicked off the whole exploring and going into that ADHD journey for me. And I was at a stage, in October 2019, I received my diagnosis, started treatment. I had just started my A-levels at that stage, after having almost been put into it kicking and screaming, not really wanting to do them. And at that point, it sort of changed my whole outlook on life and where I was going and what I wanted to do, really. So at that stage for me, I then sort of started getting into my A-levels, started enjoying my A-levels, started enjoying going to school, and enjoying learning. I sort of thrived through my A-levels, having gone through coasting through my GCSEs. I then went into my A-levels and I was enjoying them, and I was doing well, and I achieved my potential. And at that stage, I had to then make the decision on what to do next. And having gone from a position where I was completely against ever going to uni, didn't want to do it because I didn't have the self-belief to do it. I didn't believe I was smart enough, didn't believe I had the capability to go to university. And it sort of just changed my whole outlook and sort of perspective on that as well. So it sort of moved into a place where I've now gone into university. I'm studying a business degree at Sheffield Hallam, whilst also working part-time for 360, which it's 4 years ago, 5 years ago now. I would never have thought was possible.
There's a lot in there, and you mentioned self-belief. Let me flick that back to Rebecca for a second. When we're talking about being able to help our patients on and help that treatment journey, and going back to why the diagnosis is important for this patient group, what do you see clinically in that whole self-belief piece, right from the get-go of the diagnosis to going forward? What do you see clinically?
I mean, again, it's very individual, but there are, managing patients and people with ADHD and managing their treatment and being involved in their care, you see there's a lot of pattern recognition with this. So the feedback that I get as a clinician when we have managed to manage symptoms in the best way possible, and we do that with medication, I'm sure we're going to talk about that a little bit more later, is that the feedback is incredible. So, we talk about, and Archie, I was interested to listen to you say you started to enjoy going to school, and I wondered what that was about, really. So, and I think without jumping to assumptions about what you meant, I assumed that it was because you were finding the work easier or the experience easier, that things were more pleasurable about going to school because things became less of a battle for you, because that's what I hear on a day-to-day basis, not just relating to school, but relating to different aspects of life. So work, education, the impact in terms of people's relationships. Many people have struggled for years in adulthood when they've had undiagnosed ADHD. And these are the kind of things that we listen to a lot of the time. This is the type of feedback we get if we get it right in terms of the diagnosis and the management of symptoms. So was it around that, Archie? Sorry, I asked a question and answered it.
Yeah, no, yeah, definitely. I think it was sort of lots of different factors, I think, that contributed to it. I mean, the main thing was I was able to go into class, listen to what the teachers were saying, listen to what was being taught, take it in, understand it, and then apply it. And I think that was the main thing. That's something I'd never been able to do before. I sort of fell apart at the listening to the teacher teaching at that sort of first stage of the process, and I was able to then work my way through that process, really. And then not only that, it was then when it actually came to doing the work, having always felt like I feel like I'm as smart as the person sat next to me, but they're doing it so much easier than I am. I was able to keep up with the person next to me, even excel and go beyond them, which is something I'd never experienced. And I was getting enjoyment of being able to keep up with my peers. And sort of linking back to that whole self-confidence and self-belief, my self-confidence and self-belief was on the floor due to lots of different reasons in terms of that whole sort of cycle of not feeling like you're good enough because you've always been told you're not good enough because you can't do it, you're not reaching your potential, all that sort of stuff. That started to improve. So I became more confident and more outgoing myself. I started to make more friends, started to be more outgoing. And that made the whole school environment, not just the teaching and the learning, but also the social side of school, so much more enjoyable.
Yeah, absolutely.
You covered a hell of a lot there, Archie. And I'm going to pick on that self-belief piece for a second, because one of the things we work with a lot with our patient group is that anxiety that's caused by a lack of self-belief. And those of you that are on this webinar that know the work that we do, that the whole construct of being seriously which looks like depression, but it's actually an ADHD thing about I'm sick and tired of not being as good as the person sat next to me, or having to work harder to achieve less than they are, and knowing that because I got the last piece of work wrong, I'm going to get the next piece of work wrong, and the anxiety that produces. No one's going to claim that you are without anxiety now, I'm sure. But what's been the impact on your self-belief and your position in, let's say, your position in work? Let's use that as an example. Could you have done what you do now without your diagnosis?
Not a chance. No. I mean, like saying that whole anxiety thing, being constantly told or feeling like you're not good enough, and then getting stuff wrong, not wanting to be called out because you're not listening to what the teacher had said. So when you're answering the question, and that whole sort of stuff just builds up an anxiety within you of not being almost wanting to be picked out, being pulled out of the crowd because you're scared of getting it wrong because that's all you've ever done, if that makes sense. And that sort of, once I'd started to gain that confidence in myself, because I was able to move forward and I was able to listen in class, and I was able to keep up with that person sat next to me, that anxiety started to almost disappear. I mean, there's still a level of anxiety there, and I think that comes from lots of different reasons. It's not purely due to that being situationally, as you were talking about, Phil. There's lots of other reasons, but it's more manageable, and I understand it better now. I think that's the key thing. And going to what you were talking about in terms of, would I be able to do what I'm doing at work now before my diagnosis? Not a chance. I mean, my anxiety was so bad, I refused to call someone I didn't know or pick up the phone from someone I didn't know, because I was that terrified of speaking to that person, because what if I got it wrong? What if they don't like me? All this sort of stuff. And to then go into a workplace with people not only older and more experienced than me, that was one of the main things. But going into that workplace and being able to have discussions, be part of that working environment, work with them, and in some cases manage some people, not a chance would I be able to have done that before my diagnosis.
It's really interesting. Sorry, I would just no, it's just really interesting listening to Archie, and I think about Archie now in this position that he's in, doing, living your best life, really, aren't you, Archie?
Yeah.
You think about Archie as a child, and this is what occurs to me. So you think about Archie as a child, and now you're able to articulate as an adult, thinking back about your experience in childhood, struggling with these symptoms that were probably unrecognised, actually, because you were diagnosed later on in life, and not as that young child at school, not being able to articulate what those difficulties were. We do know that children with undiagnosed ADHD, with ADHD in school, do receive a lot of perhaps low-level negative criticism that's perhaps not at the higher end level that's causing problems, but that over time can create a lot of internal struggle, anxiety and worry, because it just builds up a pattern of almost like a self-fulfilling prophecy, that I've been told this, I've been told that I'm this, I'm lazy, I'm not so good, I'm not achieving. And even though it may feel low level, over a lifetime, that can create problems in itself. So it's interesting to listen to you now talking about yourself and listening to your story from when you were younger, but you've now got insight. And I always say to everybody that I talk to that insight is the greatest thing that you could ever possess, because without that, how would you know that these difficulties are relating to these set of symptoms? We know that because we're specialists, and you know it now because you've been coached through the ADHD journey, you've been treated, and you understand what that means. And that, to me, that's incredible, because this is setting you up to be able to understand yourself, your challenges and your difficulties, and what that might cause. But there's lots of people that don't go down the assessment journey, that are left with these questions and wondering. You can understand why then people do struggle with the mental health, they struggle with the mood, they struggle with anxiety. So yeah, it's just a really interesting sort of reflection, I think.
Yeah, absolutely. And there's a great question in here which I'm going to answer by asking Archie a question. There's a link. I'm going to come to medication in a minute, but if we look at the non-medical side of what you get now, you understand your ADHD. It's all too easy to dismiss the scaffolding and the support. But I know the kind of support you get from your mum, and I
Yeah.
know that she's learned that from being coached to be a mum of a 21-year-old with ADHD.
Yeah.
Talk to us about the kind of things that your mum's been coached to do for you, to help you get through life, even though you're aware and you've got that awareness, you've got that, you are medically treated and optimized. What happens for you from your mum? Because I think there's a lot of people will be able to recognise where non-medical help can really kick in.
Yeah. So, I mean, to answer a question that I saw in the chat as well, I am medicated and I am being treated for my ADHD with medication. But like Phil says, I still receive a lot of support and scaffolding. I like to call it scaffolding. It's sort of those building blocks that support around you, especially from my mum, because even though medication has been absolutely fantastic for me, the medication doesn't wipe away all those sort of symptoms and those sort of behaviors and traits of your ADHD. And one thing that I still definitely struggle with is procrastination. And so when it comes up to at university and I've got an assignment due and I've got it due and I've got 2 months to do it, let's say, what I was often finding when I first went to university, I was waiting until the last week or sometimes even last couple of days to get started on that assignment. And even though I was taking medication, I still had that difficulty with that procrastination. So now what I do every time I receive a deadline or an assignment at university, or even sometimes at work, I'll let my mum know what that deadline is. And she will then be constantly reminding me, sort of asking me for progress reports, might even send her some stuff to prove what I've been doing and show her what I've been doing, just to help support me and make sure that I'm not missing deadlines and I'm still sort of getting where I need to be and not procrastinating as much. And I mean, that's just one little thing. I mean, another little thing is I still sort of struggle with it is in the morning, because at that stage when I wake up, I'm not medicated and I struggle to get out of bed. I sort of feel a bit sort of lethargic and can't concentrate enough to get myself up, out and ready and go to work. So what often happens is my mum will give me a call every morning. I'll message her the night before and say, right, I need to be out this time, so can you give me a call an hour and a half before? And I'll receive that call an hour and a half before to make sure I'm up, to make sure I'm getting ready, to make sure I'm on the go, just as that sort of safety net. And I know as a 21-year-old lad, that's not normal for someone who's neurotypical, but I think now I understand my ADHD and sort of recognized what difficulties I still have, even though I am being treated and medicated. It's still understanding that and asking for that support and asking for that help and not being afraid to ask for that help. Because I can imagine most people my age especially would think, God, still getting help from your mum to get up out of bed, might be quite embarrassed by it. But for me, I sort of embrace it and say, I appreciate that help, because I understand where I need to come, need to learn and need to improve and still have difficulties, and I can still get that help from my mum with that.
Absolutely.
It's hard not to get emotional when you listen to this, isn't it? It's hard not to be so empathetic with the honesty that you're portraying here, Archie. So you if you're looking at the chat, which I think you are, then I'm going to mention two things. One is you can feel how you're giving people affirmation here that they're not alone from hearing your story. But secondly, I want to go back to the audience and say, this 21-year-old young man with ADHD is currently partaking in a big debate about a subject that is close to his heart, thinking about his own response and reading the chat. And I think the chances of doing all of that without his treatment and his support would have been minimal. So there's a living embodiment of why a good, solid diagnosis is important right in front of us. There's a question here, Archie. I'm going to come to you in a second, Rebecca, if I can. Does the medication deal with your procrastination completely, Archie?
I mean, the simple answer and short answer is that no, it doesn't. I still struggle with procrastination when I'm on my medication. What it does help with, though, is providing me with all. It's not motivation, but because my difficulty was, especially with my procrastination, is I might write a couple of words on an assignment or whatever, or read a couple of pages of a textbook and then just stop there and not do anything. Don't know where to go. Don't know where to go forward. I describe it as almost being paralyzed on that sort of first page or first few lines. So what it does help with is that writing of those first few lines, and then it allows me to sort of think and process, to allow me to think, right, what do I need to do next? What do I need to write next? What's my plan? And allow me to sort of help me move forward. And that's one thing it has helped me definitely, because one thing I never used to do was plan in terms of what I was going to do in terms of my work and sort of homework or exams, assignments, whatever. And I think that's where a lot of my difficulty sort of came from, was that I didn't know where I was going or what I needed to do in terms of that piece of work. And what I hadn't done was plan previous. And so that procrastination on that sort of first few lines often came from not knowing where to go next, I think, really. Whereas now I'm medicated, I can now process, think, right, this is what I need to do to get this piece of work done. I'll create a plan, so I now have a better idea of where I need to go. So I'd say that's kind of a better answer, I suppose, really, of what it's done for my procrastination.
Rebecca, coming to you about the whole piece of procrastination and it still being resident in a person with ADHD, one of the things we often find is that if the person is motivated for the particular thing that's in front of them, procrastination is reduced because of the impact of motivation. But what do you find with patients once they've got their diagnosis in terms of their motivation to go into a treatment pathway, whether that 9 times out of 10, it's a medical treatment pathway? What do you find about that newfound joy of, I think when you assessed Nadia on Loose Women, she talked about the pink cloud, didn't she, of wanting to investigate more and get to grips more. What do you find clinically in that regard?
So I think you know, for adults that I've assessed and treated, it's once somebody's been brave enough to say, right, I need some help. I need some help here. I need to understand this. I need to recognise. I need to move on from what's happening. Once people get to that point, they're usually at the point of then wanting to try and manage these things in the best way possible. So that treatment discussion isn't that challenging at this point. I think there are a lot of other considerations for individuals based on lots of things around maybe some of the myths that people have heard when they've read certain things on social media, or they're going to certain peer support forums where people are talking about their experiences. You're always going to get the good and the bad, aren't you, with those things, and something, nothing in between. So I think a lot of it is around providing that evidence, those facts, those figures that can sort of coach people into thinking about how they can have some positive results with treatment. Now for Archie, and it's really interesting listening to Archie's sort of progress, because you describe yourself as being stable and treated, and yet there's still a part of your ADHD which needs to be managed by strategies. What I will say is, for some people, that procrastination can be managed with treatment, not for everybody. And this is why we have to look at people as individuals. We look at things on a case-by-case basis, and we have to be realistic about what treatment can offer. But to be quite honest with you, it's difficult to predict with a person that you are assessing at that time how they will respond to treatment. We know there will be some, if the diagnosis is right, there will be some positive response to treatment as long as the medication is tolerated, but to predict in what domains that will be is very challenging. So this is where the process of the follow-ups, engaging with the patient, ensuring that you're listening to what they're telling you about what is then left after we've achieved everything that we can realistically achieve with medication, is really important, because then what you have is, like Archie, understanding what is left to manage after what can be treated is treated in the best way possible.
Absolutely, and it's working with those around you and to see what there is. And I think we still have on our web on each patient's portal, post being optimized on medication, there's a questionnaire that people can undertake to find out what their executive function deficits are going forward. And it's a huge piece of, as Archie's described, post your diagnosis, solid diagnosis, treatment, optimized to as close so you can lead your best life, but your best life may still need help. And this questionnaire helps you work out which are the functions that you need help with, and that's a really good guide. And as Archie's explained, your mum helps you with those those things that you need help with, not least of which is getting up and starting and going and cracking on. Let's talk about something else for a second. One of the questions, which we're going beyond the solid diagnosis here, but I think it's right to stray beyond it because a couple of people have asked the question. Did you get the right medication first time, Archie? There's a great question because I know the answer.
Yes and no. So when I first got diagnosed, I originally started on Elvance, and Elvance was working really well for me. Sort of got up to Elvance 70 milligrams, and I felt like, yeah, that's right for me. I felt like this is where I need to go moving forward and stay on Elvance 70, and that was working well for probably about 3 or 4 months. And then what sort of started to happen was, as my medication was wearing off, I would family would notice I'd sort of become quite argumentative, quite aggressive, quite angry as my medication was wearing off. And as we know now, that was due to my autism, which I didn't know at the time, and that my autistic tendencies, that sudden change within me of suddenly being amazing, fully optimized on Elvance to suddenly bang nothing, caused quite a lot of conflict within me, and sort of that then led me down to looking down the autism route from that. So what we decided to do was have a look and sort of see where else we can go. I then tried Concerta next, which is a methylphenidate based product. Unfortunately for me, I'm a non-responder to methylphenidate, so the Concerta did nothing for me. So what we had to do was then decide, right, well, Elvance, which is an amphetamine based product, I'm an amphetamine-based responder, so let's have a look at the other products within the amphetamine group to see what would work for me. And so now I've sort of settled, and I have been for sort of the past 2 years now, I think, on Amphexxa, which is a immediate release medication. So I take Amphexxa 15 milligrams 3 times a day, and I seem to be relatively settled on that now.
Excellent. And you know, I know that you can talk and wax lyrical for an hour on the medications and the different effects on you, and there's probably something in that for the ADHD community in the future of perhaps coming back to you on that whole medication journey. Rebecca, there's a great question in here, and I'm building off this clinical expertise, this specialist expertise that we bring to the table. And I want to pose the question, how do we choose what medication to start a patient on? And let's answer that question as if there was every medication available at the pharmacy, as opposed to the current situation where we know we've got international shortage. How do you make the decision? And importantly, as a lead trainer in our academy, how do you train other clinicians on how to start that journey?
Yeah. So if we go back to the beginning and we look at our patients, what we're going to do first is look at a person's medical history. We're going to look at whether or not, and I'm taking it right back to basics here, because we have to look at people as an individual. We have the guidelines, we have medication guidelines, which I'll talk about, but we look at the person first. So what medications can be safely prescribed given an individual's medical history? And there are different conditions that need to be considered. I suppose we wouldn't have time to talk about them all at great length, but there are certain conditions that your clinician will be aware of that we need to perhaps consider different medication choices. So if we look at we follow NICE guidelines for management of ADHD symptoms, and the NICE guidelines quite clearly state that we treat first line with stimulant medication. And the reason that we do that, very briefly, is the stimulant medication regulates the production of the 2 main chemicals in the brain that are affected when somebody has ADHD, which is the dopamine, norepinephrine. So that's what we're trying to regulate when we introduce something like a stimulant medication. Now, when we start an initial treatment, either of those products, so Archie spoke about both of the medication groups, the stimulant medication groups. The first one is amphetamine based, and there you have your Elvance and Amphexxa, and the second is methylphenidate. Slightly different for children and adults. So with adults, we can start with either of those stimulant groups as first line. For children, it tends to be methylphenidate based first and then switch if they're not responding to methylphenidate. So it's a little bit different depending on your age. Now, for me as a clinician, when I'm speaking to a patient, we're discussing and deciding what medication we're going to trial first. Really, it's around the patient's day and what their waking day looks like. So medications have different lengths of duration for symptom management. So something like Elvance can last for 10 to 12, sometimes over 12 hours, which is about treating a person's symptoms during the waking day period when they're at work, busy with the family life. So lots of ways in which we can manage symptoms. The Concerta set tends to last a little bit shorter. So again, it's a very individual approach. And to be honest, we know that a person, from my experience and from the clinical research papers, that you will respond to one stimulant group or the other. So we try one and see if you're a responder to that stimulant group. How we do that is to check first whether you are tolerating the medication and whether the medication is effective. So what we need to see is a reduction in the symptoms. So the symptoms should be able to be easier to manage during the waking day. So what we hear are things like improved focus, ability to concentrate better, able to focus without being distracted internally, distracted so easily externally. If you are somebody that has impulsive hyperactive symptoms as well, we're looking for reduced fidgeting, movement, restlessness, ability to relax, all will improve if that medication is effective. We then really, so it's not as basic as choosing a medication, as Archie well knows, because it is about choosing the medication and then getting the dose right. And that is all about the balance of tolerability and efficacy. We want all the positive effects, but tolerating the medication is as important. So we must make sure that we monitor the presence of those side effects as we're going. And there are a few very specific side effects that we monitor as we're going along. So that tolerability is as important as the medication working. You know, lots of people will be reluctant to continue to take a medication if they are experiencing side effects. So we have got choices, we've got options. If the first medication is not effective, once we titrate up to a dose that is a therapeutic dose range for your age, then we will look at switching and trialing the second stimulant group. We also have non-stimulants, which are classed as third line after both the stimulant groups. They're slightly different in the way that they work. Some people do find, and it's interesting that Archie was saying, and if you don't mind me referring back, Archie, to that drop-off that you felt with the Elvance in terms of your autism, and that's quite common. So that's something that can be quite commonly fed back to us as clinicians when people have got diagnosed or undiagnosed autism or autistic traits, that change in presentation can feel quite difficult to manage. So you're having all this really great progress during the day, and then all of a sudden it feels like, and people have described it like they're dropping off the end of a cliff at the end of the day. Sometimes and not exclusively, but sometimes the introduction of something like a non-stimulant, which is a 24-hour medication, can mitigate that a little bit, because it's almost like a steadier release that doesn't drop off. It's just an accumulating medication, a little bit like an antidepressant would accumulate up in its dose and therapeutic range. So those medications can be used, for people that do struggle to tolerate the stimulants with the side effects, or they don't respond to a stimulant, or if a non-stimulant is preferable for some of the reasons that you've talked about. And there's quite a few nuances around the medication management, really. But I think the primary theme and the message that we give to our staff when we're training our clinicians is to think about individuals and their medical background, their history, the difficult times of day, what stimulant they're likely to respond to, and then have that sort of that ability to be able to switch if they're not responding, and be able to measure that as you're going through the process, really.
So undoubtedly a very long answer and a complex answer.
It is complex. There's no way of saying it easy, really.
Yeah, it's complex. but I think the nuts and bolts of that are that it's a patient-centered decision, not an organisational decision. And it's very much about what the presentation is about the patient, what their lifestyle, what their expectations from treatment are, And if the first medication group doesn't work, we would switch into another medication group, and there is the third, the non-stimulants, if we need to go there for either an immediate cause of potential side effects or lifestyle, or indeed not tolerating side effects. Now, there's a really, I'm going to switch the lens here, excitingly, because there's a really great comment in here, and I'm going to come to you, Archie, on this one. I feel like my autism and my ADHD are constantly arguing with each other. And there's this amazing dichotomy, which I don't think many clinicians understand. And that is, how could you possibly be impulsive, ADHD, and actually need a rigid structure to get through things, autism? And those two competing against each other, I know from talking to you, Archie, you have both of those needs to manage impulsivity, but also to be defined with rigidity for the autistic side of you. How's that for you?
Like you say, it's a really sort of almost an oxymoron, that sort of having that need for rigidity and but that impulsivity and stuff like that. It's weird. And for me, sort of the autism, it never really occurred to me until it was about 2 years ago. And the way I describe it is that my ADHD was so loud you couldn't hear the autism, and that's what was happening pre my diagnosis and pre starting medication. So my ADHD was so loud that you couldn't hear the autism, and the autism wasn't able to show itself. There might have been traits and stuff like that here and there, but nothing there enough to pick up on to sort of think, oh, that might be autism. But now often what I find is now I'm treated, now I'm medicated, now I'm stable and optimized on my medication, is my autism's got a lot louder because my ADHD is quieting down. And with that comes new challenges for me to face in terms of what the autistic tendencies bring in terms of that need for change, that need for no change, need for rigidity and that sort of set structure and set plan. And compared to before, where I'd never had a plan, didn't know what I was doing when, and had sort of complete chaos in terms of what was happening in my life, I've now had to sort of learn and adapt to constantly needing a plan, knowing what I'm doing when, knowing where I'm going when, and stuff like that. And there's sort of been quite a lot of adapting to that sort of difference in sort of behaviours and needs, really, for me. I suppose, does that answer your question, Phil? Or
it does. I'm going to come back to you with a supplementary question. How easy is it for your mum to change your plan?
Oh, she has an absolute nightmare trying to do it. I really struggle with that change. Once I've got a plan set out in my head that's been sorted and agreed, I really don't like to sort of move away from that. It causes a lot of anxiety within me. So wherever possible, if we set a plan, we try not to change it where we can, because not wanting to cause that anxiety and that conflict within me, really.
Archie, did you feel? Oh, sorry, Phil.
No, go on, please.
It's a burning question, really. So, Archie, did you feel like, because I'm just thinking about the timeline of events in terms of your care and treatment, and you were sort of recognising the autism later than the ADHD. Were the autistic traits more evident to you once your ADHD was better managed, do you think? Because this is something that is quite common in terms of that autism ADHD presentation. Was that the case?
Yeah. So yeah, it's once I got my ADHD symptoms controlled, once I was stable, sort of describe it like clearing the fog. You could then see the autism, because what we've done is got under control my ADHD symptoms. So, and then we were seeing, right, this is what's left now. What else can we see? So yeah, so once I got stable on my medication and had better control and understanding of my ADHD symptoms, yeah, the autism became much more prevalent.
And you're absolutely right. We have a lot of people that will report the same thing. So perhaps not so much, you can't see that autism. There is that internal sort of struggle there, isn't it? The need and desire with autism to be structured, plan, organisation, but with the ADHD overpowering that chaos, unorganised. So that there's that real internal battle, really, isn't there? Once you manage one can be managed with medication. and the other is about looking at things like adapting lifestyle changes or recognition of those traits and how to manage them. So it's really interesting that it happened that way. And to be quite honest, from a clinical perspective, we see it quite a lot once we have managed those ADHD symptoms. So it's interesting that we're saying for you, Arch.
If we lighten the load for a second, I know there's an anecdote that goes on in Archie's house with his mum, where Archie's ready to initiate the plan. Let's say that plan is going out shopping and the plan is to go at 6 o'clock, and your mum's not ready, Archie. You give her a clue that you're just about to get very anxious about this and the plan isn't being lived and delivered. And what is it that you say to your mum that she knows now is the number one clue? You're about to absolutely lose it.
Yeah, I'll either be stood by the back door, go to the bottom of the stairs with my shoes and the coat, and I'll go, right then. And that's the clue that, right, we need to get going, is when I say right then.
Yeah, and those little, the hilarious parts.
That's quite polite, Arch.
Yeah, it is, yeah. Yeah, it's quite under control. And there's a question here from Megan in the chat, about it is common for people's autism to be kind of discovered, in inverted commas, after treating the ADHD. And I think Archie's articulated it really well there. What is really common, as Rebecca said, is the noise of the ADHD overwhelms the autism. And once we get that noise dampened down, we then know what we've got left to work with to really enhance the quality of that person's life and really make a difference. And you know, that is a fact that we should all embrace. And I think previously, when people didn't understand this as much as they do, and I'm going to come back to something else about being a specialist in this arena, when people didn't understand it as much as perhaps we do now, there was an opportunity to interpret, my ADHD treatment has made me worse, not better, I'm going to stop this, because we didn't actually understand what the significance of quietening and dampening down that noise was, to allow the rest of the person to come to the fore, so we can start to build those coping mechanisms. And the specialism, you know, Rebecca and her clinical colleagues are working in ADHD 24/7, all day, every day. And there won't be, in clinics up and down the country, there won't be that emphasis on a specialist subject in many other clinics in the country. And the level of expertise, reading, lived experience with the patients that you get from that focus, Rebecca, day in, day out, has allowed you to flourish, hasn't it? I've seen that since you joined us, allowed you to flourish as an absolute specialist in the field. How do you feel professionally about being that specialist now, coming from a fantastic CV of mental health work in all sorts of aspects? How do you feel about that specialism?
Well, I think for me, like I said, it's the specialist. It makes me feel proud. So I'm proud to be an ADHD practitioner. I'm proud to work and deliver the service that I do. I think, you know, we need to be honest here. We do get some criticism in terms of clinical backgrounds. You know, I would say to anybody that is looking for an assessment or looking to have their symptoms understood, that a specialist service is the way to go, really. Clinical background in terms of discipline is not relevant. We're looking at that specialism, and that specialism is about somebody living and breathing this specialist subject, which is what we do. So there will be very few things that I have not heard, have not learned, have not read, have not researched that is around my specialist subject. And I think that allows a greater depth and quality to a service that we can provide. And I think that that's what we all deliver with this organisation. I mean, internally, we're talking to each other all the time. When we do look at new potential recruits for us, the thing that I will say is, I've never worked in a service whereby this level of knowledge and expertise is shared on a day-to-day basis. We live and breathe this subject matter. We live and breathe ADHD. We live and breathe this clinical sort of work for our patient group. And I think that just enhances the level of service that you receive personally, because this is, you know, we're not talking about general subjects. We're not talking about general psychiatry. That background knowledge is useful, but being a specialist enables you to deliver, I think, just next level service, really.
We had experience recently of of an expert or acclaimed expert in ADHD, who was a generalist psychiatrist, whose first line in a meeting was so compounded wrong on understanding ADHD. We were quite shocked, and we have to make that distinction between specialism and generalist in the world of psychiatry. And as Rebecca so rightly said, and I was proud to hear you say how proud you are to be that specialist in that field, Rebecca. And we do have a complete mix of backgrounds and disciplines in the organisation to turn to those other things if we need them. But what we do have is that specialist acute focus. I'm going to change the lens again here. There's a great comment here from David. Hasn't yet started his medication journey, but is getting by having a Red Bull most days. And ergo, the common caffeine, the whole common caffeine self-medication. Now, where are you, Archie? And I know the answer, so I'm asking that you should never ask a question if you don't know the answer. Where are you, Archie, with your medication and caffeine?
So I mean, a little bit like David, prior to my diagnosis, to sort of get through school, I'd be having 2 or 3 Red Bulls a day. One when I got up in the morning to get me right through the morning, one at lunchtime, and then one mid-afternoon. But once which was not healthy at all, having that much caffeine during a day, as well as having Coke and all that other sort of stuff. And so,
I was going to say,
yes. And so what I decided to do is, when I started my treatment, bearing in mind I knew that caffeine was a stimulant, and that sort of can affect your blood pressure and your heart and stuff like that, on top of what I was going on to in terms of Elvance, which was also a stimulant. What I decided to do was cut out caffeine completely, thinking I don't want to double up, I don't want to affect my body, I don't want to do damage to my heart. So at that stage, I sort of said, right, no more caffeine. And what I also found at that stage, when speaking to my clinician Lisa, was that it's one of the most beneficial things you can do, because then we can fully understand, right, this is what the medication is doing for you, so you can separate it away from what the caffeine is providing for you in terms of that sort of self-medication and support. So I would really suggest anybody who is going to start treatment is not necessarily do what I do and go cold turkey straight away on caffeine, but try and reduce your caffeine intake as much as possible. So I've now gone nearly 3-4 years without having caffeine, and I don't miss it, is what I'll say. I feel better for not having caffeine, really.
And there's a lot of commentary on sugar, chocolate, and there were some questions earlier about diet and how important diet is. And I'm going to lead that into, we know the solidity that we require from the specialist diagnosis, and we know now how we would initiate treatment. It's worthy of just moving on a second into, how does diet help or not help the patient with ADHD? And Rebecca, you're on warning, I'm coming to you. I'm going to talk to Archie first about puppy fat and weight loss. Where were you when you started your treatment journey? Because we mapped that recently, didn't we? We actually charted that as a graph. And what did that reveal for you?
So when I started my journey, I was overweight, and I had a lot of, sort of, like you say, sort of fat that I needed to burn and weight that I needed to drop, because of impulsive eating, binge eating, being bored, so I'll eat, or not knowing what to do, or it's, there's just some crisps or some biscuits in the cupboard, I'll just have them impulsively eating, and which meant that I was putting on a lot of weight. And at the point that I was diagnosed, I was about 14 stone, whilst being about 5'10", which wasn't healthy. And what I found was within the sort of the first 6 or 7 months, the weight started to come off naturally, because what I was stopping doing was that impulsive eating, the sort of the bad habits of when wanting a snack or needing a snack, I'll just go to the fridge and get some chocolate or get some crisps. I was then actually thinking, right, I'll have a proper healthy snack. I might have a sandwich or something like that, something better, because I had the sort of understanding and the capability, and not just thinking, oh, I'll just get bored making a sandwich or making something healthy, I'll just go what's quick and easy. So I was able to do that, and what I found was, I think it was probably about 18 months into my journey, I'd lost nearly 2 or 3 stone, getting down towards that 12 stone mark and that healthy weight. So it did wonders for me in terms of being able to plan, not only plan your food and plan your diet and plan your daily meals, but also cutting out that rubbish eating, that sort of impulsive snacks sort of stuff. So yeah, it really helped.
I remember you telling me a story of how you'd gone shopping to get your evening meal, and you'd gone to one supermarket for one set of ingredients and another supermarket for the other because they would be cheaper. And I remember reflecting as you told me this tale of that would never have happened without the diagnosis and the treatment to have that level of organisation skills to actually plan a proper meal. Rebecca, what advice do you give your patients on diet? That, you know, springing off what Archie's just journeyed us through.
I mean, there's quite a few things to consider when we're thinking about things like diet and side effects, actually. And I noticed just a quick comment that popped up there, so I think it's important to acknowledge that as well, so that the medication can, as a side effect, contribute to appetite loss. That's different to management of symptoms, different altogether. And both of those things need to be monitored, because what is important is that we understand the reason for weight loss if we see it during a patient's treatment journey. So what Archie really nicely described is one of the couple of the really common things that happen with people with untreated ADHD. So firstly is binge eating can be quite a predominant feature of their ADHD, and that can be around pleasure seeking. So we're trying to stimulate that dopamine. And if you stimulate the dopamine, you're going to be able to feel more satisfied. It is, you know, essentially a reward chemical, dopamine. It's going to be increased if you eat something nice. That's why it can, untreated ADHD can contribute to quite a lot of binge eating as part of people's symptom profile. Also, people with ADHD do or can struggle to plan, organise and prepare meals. Now, if you think about the difficulty with planning and organising day to day for people with ADHD, planning meals is really difficult. You've got to think about it. You've got to choose ingredients. You've got to follow a recipe, follow instructions. You've got to make the meal. All these things are a lot of steps to do in order to have a meal, when actually what you could do is something quick and easy, like reach for a bag of crisps. So we can see lots of reasons as to why people's diet can be impacted really by untreated and treated ADHD. So what's important, I think, is when we are managing symptoms, is to look at whether symptoms are being managed, so those things are reducing, the binge eating is reducing, the ability to plan and organise is improving, so diet and healthier choices are being made, or whether somebody is struggling to eat because of a side effect of medication. And that needs to be managed separately, really, because there are people that maybe won't be overweight and that aren't binge eating, and they may be concerned about appetite loss as a side effect of being treated for the symptoms.
And there's a whole series of webinars we ran earlier in the autumn on ADHD nutrition, ADHD and diet, and I would encourage anybody to go to that back catalogue and have a look at those. They really were. We were working with a dietitian who'd taken time to specialise in ADHD, and they were quite, to coin a phrase and be a bit crass, they were quite stimulating. Good content in there. We're going to wind out in a second. Look, that's been the quickest hour of the week, that's for sure. So as I wind out, I'd encourage both Rebecca and Archie to try and think of a takeaway for people. That's a food analogy. If nobody got that joke, that was just a little bit too subtle.
Really.
And as I wind out, I'll come to you two guys to close the session. There's a number of teachers in the group chat there. Watch out for our newly revamped, soon to be relaunched schools toolkit, which we're quite excited about. And a number of people have asked about right to choose in the chat and how that plays out. Again, there's guidance on our website on right to choose, and we proudly are a right to choose provider for the NHS, which allows you to choose your provider of choice wherever your geography, as long as you are in England under NHS rules. This month, we'll see a record month for ADHD 360. where I would hope that tomorrow we will assess our 1,200th patient of this month for the first time ever, which we celebrate in particular style in relation to our lost colleague Dave Scarrett, who assessed 400 patients. So every time we round out at 400, we celebrate Dave, and we will be doing that for the third time this month, which is huge for us as an organisation. And I mention that because of the pride we have in the work that we do. A number of people have asked about the medication shortages, the international medication shortage. I think we're managing that really well as an organisation. We are still treating patients, we're still assessing patients. We're in constant daily dialogue with the industry. We've got some fantastic relationships with the manufacturers. And hopefully next week, we're going to be the launch customer for a new drug in the methylphenidate range, which will be able to plug the gap a little bit more as well. And we've trained our clinicians on that already. So there is hope. And I mentioned that deliberately, there is hope and something to celebrate, that all is not lost. My last words are, this has been a fantastic expose of what a solid diagnosis should do and could do for people. But without Rebecca, it would have been nothing. And without the amazing Archie, I think this would have been quite dry. I've asked if you can get, Archie, a transcript of the commentary, because I think you will find that quite rewarding. You know, all that self-belief and any imposter syndrome you live with daily will be smashed out the park if you read the commentary back when you can. Takeaway, I'm going to close with you, Archie. I'm going to come to Rebecca first. What's your takeaway?
So for me, I just want to echo what you say. I think, Phil, I've really enjoyed sitting, and I know it's been us talking, but I'm kind of keeping my eye on the chat, and there's some fabulous comments coming through, some fabulous questions, and as a clinician, obviously, I want to answer everybody's questions, and we can't do that. We would be here all night, and I would happily sit here all night and do it because I am so passionate about this. For me, I think take home, if we're thinking about the subject, which is what can a solid diagnosis do for you? To me, I think there's no delay. If you are thinking that these symptoms are affecting your life, explore them and go through that process. It isn't scary. You know, I'm a clinician. Hopefully I'm not too scary. A lot of the clinicians are, you know, we're patient focused. We want to help, and that's genuine. And all I can say is there's no too early a time, no too late a time. We assess our children, we assess people into adulthood, you know, at any point at different stages of their life, each with a different story as to why they've eventually come for assessment. So, you know, for me, I think just be brave and do it. You don't know until you do.
Archie, follow that.
Yeah, I was going to say, I suppose echoing what you both said, but I was going to say for me, and sort of reflecting through this evening in this webinar, I think one thing that's really stood out for me is what a good diagnosis can do for you is help you understand yourself and help you understand your ADHD. Because as soon as you can start understanding what's going on in here, you can start making meaningful change, and that's when you will start to live your best life. So what for me, for what a good diagnosis can do for you, can help you understand yourself to improve and start living your best life.
There's commentary about, if you need to get hold of us, give us a call. The medication shortage has completely overwhelmed our phone lines. We've done a lot of work over the last 3 months to try and get on top of this. Those of you who are patients will see that we've introduced the self-serve process in the webpage. It is difficult to get hold of us at the moment. I know, I empathise, and we're suffering for it. But please do persevere, because we want to hear from you. We do want to hear what your needs are, and we want to help. But I know it's not easy at the moment, and I respect that. I respect it immensely, that it's a challenge, but we are working hard to overcome it. I would just like to wind with one last comment. And despite all the challenges you bring into everything every day, with your ADHD and how difficult it may be, I want you to just look at that lad in the England shirt in the corner of your screen there, and just realise that there is an absolute journey that you can go on that will change your life. And I think Archie embodies that and is a brilliant ambassador for the ADHD community. And Archie, you and your family should be rightly proud of everything you achieve and everything you do. And I'll take my hat off to you as we close out this evening. we've got the embarrassment of sitting here to debrief things, which we won't start until everybody's come off the webinar. And Kristen, who will pop up on the screen at the moment, she knows that we find this rather hilarious, and there's always a couple of people who hang on to see what we're going to talk about. Well, we ain't going to talk until you've gone. So I'd like to say thanks ever so much. Do keep in touch by means that work, and we will do another webinar soon. And I suggest that we'll probably see Archie again in a webinar in the not too distant future. So thank you, everybody, and we'll wish you good night.